Dear friends, good afternoon. Let me follow our schedule. And today we have one more lecture on clinical pathophysiology, which is devoted to gastrointestinal pathology. You know that this group of diseases are very widespread in the whole world, in any country, any gender, any age group may be affected by various of gastrointestinal pathology. And so today we shall try to understand more about possible reasons, of course, mechanisms of GIT pathology development, and some principles of treatment and prophylaxis of this group of illnesses. First from the first, let's pay some attention to causes to etiology of gastrointestinal disorders. Many organs are involved, so many causes may be. And first from the first is inappropriate diet. Because main function of GIT is digestion. Surely, diet is very important. What do we mean? Talking about diet, inappropriate diet. Inappropriate means, first of all, composition. If you have very often junk food, for instance, it is proved that junk food, fast food, gives many problems, not only in GIT, by the way, but also we know about cardiovascular consequences, about some maybe kidney pathology, other disorders. But not only composition is important. Also, it is important that when and how regular do you have your meal. You know that GIT secretion and motility are both regulated by a nervous system and endocrine system also. And nerve regulation may be divided onto conditional and unconditional reflexes. So unconditional are inherited, but conditional are formatted, are made during the life of an individual. And if you take meal regularly, your juices of GIT are secreted regularly too. But if not, there is a chaotic situation when secretion is already here, but meal doesn't arrive. And especially it is about stomach, but not only. Stomach juice is quite aggressive thing, quite aggressive substance. It may damage mucosa and produce some problems. We will tell today what problems may be. And inappropriate diet also may cause some neurological disorders like anorexia nervosa or bulimia. Also because of inappropriate diet and connected neurosis-like disturbances. The second group of causes, very important, is infectious. Many GIT disorders are of infectious nature. 20-30 years ago, we were sure that gastric ulcer is absolutely non-infectious somatic disease. But today, we know that one of etiological factors is Helicobacter pylori, a bacteria. But not only ulcer is involved, You know that in history many dramatic facts maybe when infections affected millions, billions of people and killed millions of tens of thousands or hundreds of thousands people. And many of these infections were GIT infections. For instance, it was cholera, which killed millions of people in Asia and in Europe also. And even nowadays, cholera doesn't disappear. Now we still live in the fourth pandemic of cholera. It doesn't mean that millions of people will die, but if prevention measures became worse, it would be a situation then cholera again affect many people. Not only cholera, other GIT infections also exist, like dysentery and some parasitic infections also takes place and still affect people in many countries. And also viral infections exist which may affect GIT. So infectious factor is still very important. Next group, some chemicals and radiation. Toxins may be of different nature, industrial or naturally biological toxins of toxic plants, toxic animals and insects. Radiation also is an important factor. Time to time we hear about some disasters on atomic plants. And you know, one of the form of acute radiation sickness is GIT form. So we should remember about this, the possibility of radiation exposure. Next group is our bad habits: alcohol consumption and smoking nicotine. They both may damage directly GIT and indirectly also indirect effect also present because both nicotine and alcohol act on blood supply and at the same time they are able to act on nervous system, and through this mechanism they may damage innervation and may disturb functions of GIT. Separately, we are talking about professional hazards, professional factors, occupational factors which may exposure GIT. For instance, different chemicals like aniline, like some remedies which are synthesized on chemical plants, they may appear in GIT and affect it. Next group, emotional stresses. I would put it number one, by the way, or at least together with inappropriate diet. Because inappropriate meal intake and emotional stress are tightly connected. Many people in stress situations start to eat more. Some other people start to eat less, or positively. But both situations are not physiological, are not normal. And if this situation repeats or lasts for quite a long time, it may seriously affect GIT. Many organs, not only stomach, for instance, but also intestine. You know, now we distinguish such disorder like emotional ulcer, so-called emotional ulcer or stress ulcer. Also, we know irritable bowel disease, which is not organic illness, but it is a kind of neurosis. And many other such disorders we can distinguish. So emotional stress being prolonged, being repeated, formates the area of high excitation, dominant focus in central nervous system. And this focus, as you remember from normal physiology, this focus affects other centers, as in cortex, as in subcortical areas, and at the same time it may involve hypothalamus, endocrine regulation, and disturb endocrine regulation of GIT. So the last group is endocrinopathies, very tightly connected with previous group. You should remember that in the real organism, it is the united system of regulation, neuroendocrine. It is not separated really in the real life. We separate it for convenient study, but we must remember that it is the united mechanism of many steps. Many endocrinopathies directly affect GIT, for instance, some edema like gastrinome, for instance. It may produce hyperacidity, or even indirect action of some endocrine disorders also may affect GIT, for instance, in diabetes mellitus, due to neuropathies, maybe problems with motility of GIT. So many groups exist, perhaps some of them are not included here in this slide, but now we shall follow our schedule, and some more groups may be named now. Before we start discussion about particular disorders, we shall understand well such point as dyspeptic syndrome, because in the majority of GIT disorders we are talking about this syndrome, and we must be sure what are we talking about. So this syndrome includes some symptoms as in any syndrome, and first is pain. Pain is always in dyspeptic syndrome. Pain may be of different localization, different intensity, irradiation, origin, but pain is almost always in dyspeptic syndrome. Almost constant thing in this situation, because many receptors exist in GIT, and they are irritated almost in any time of GIT disorders. Also, in dyspeptic syndrome, we may include nausea and vomiting. It is not obligatory that nausea and vomiting will be in any GIT disease, but quite often also they are present. Why they are often present? Because irritation of receptors, doesn't matter what receptors, mechanoreceptors, chemoreceptors as well. This irritation, these signals are propagated through the nervus vagus to the medulla oblongata, where, together with vital centers, together with centers of nervous vagus, are specific centers which regulate motility of GIT. We call them vomiting centers, but it is not so correct name, because these centers are not responsible for vomiting directly. They regulate motility, but sometimes the excitation may be so high that they produce opposite peristalsis, which is named vomiting. And before vomiting, a patient feels unpleasant sense, nausea. So this is also components of dyspeptic syndrome. The next component, possible component, is heartburning. Not obligatory, but if high gastric acidity, for instance, or in some cases of vomiting, also maybe this unpleasant sensation of burning in the area of esophagus, retrosternal area. Regurgitation, also maybe or maybe not included in dyspeptic syndrome, but regurgitation, at least it is a signal that something wrong in GIT, obviously. Regurgitation may be of different composition, may be connected with high acidity, heartburning, and it will be acid regurgitation, or maybe connected with hypoacidity and maybe of full smell regurgitation because of bacterial contamination. Then next component is appetite disorders. Variety of disorders may be. We know that in many countries nowadays many people suffer from anorexia nervosa. When people refuse to take meal, voluntary, of course it is a kind of neurosis, together with opposite situation, bulimia, and sometimes maybe not so severe disorders like less of appetite. It is not disappeared, but it is less than in norm, hyporexia, or maybe slightly increased hyperexia. But anyway, we shall find out whether your patient has or has not any appetite disorders, because it may indicate on GIT disorders or may indicate on high nervous system activity disorders as well. Then some disorders of intestine motility also are included in dyspeptic syndrome. First is diarrhea. Increased motility. We will tell today about diarrhea mechanisms. Opposite situation, constipation. Inhibited motility. We will also discuss today the etiology and pathogenesis. And very often, as diarrhea, as constipation may be accompanied by meteorism, gases excessive production because of many processes which are disturbed in GIT. So please remember what dyspeptic syndrome includes and what may be in dyspepsia. Now we shall go to the gastric motility disturbances. Briefly about possible types of motility disturbances. Normally, here, gastric motility includes two phases. The first is increased and then slowly decreased motility. But it is normal situation. What may happen in disturbances? This type is called breaking type. When motility is primarily inhibited, two phases may be found, but they are both inhibited. Or positively, excited type exists, when also two phases are correctly distinguished, but they both are increased high motility in the first phase, and then decreased is also on the high level. And the first type is inert type. Two phases exist, but the first phase is very long phase. You can see motility for very long time is not changed, is not decreased. Asthenic type, next one. Asthenic type is characterized by very short first phase, and also the second phase in a short time drops down to minimal level, so it is called asthenic. And the last one is chaotic type. Actually, in chaotic type we cannot distinguish two phases. Short increase and decrease of motility sequences are repeated during the very long time. The most important and the most frequent stomach disorder is stomach and intestinal disorder is stomach and duodenal ulcer. As you know, it is a chronic disease with polycyclic course. It means the relapse and remission sequence is typical. And it is based on the mucosal defect, ulcer. Here it is an ulcer under the endoscopic view, typical defect. Now let's see how is it formatted. Some statistics before. You see the number of annual morbidity in gastric ulcer per 1,000 people every year. And you see the dependence on the age and gender. The interrupted line, it is graph for female. The uniform line is for male. You see, primary males suffer from ulcer more than female. And also males have two peaks, about 30 years and about 50. But this curve doesn't drop to the zero, whereas female's curve drops to the zero about 70 years old. And primary females have less morbidity in gastric ulcer. What factors are important in the pathogenesis, etiopathogenesis of gastric ulcer? First, from the first, historically and logically, it is dietary factors. What is included in dietary factors? First of all, it is a regular meal, because gastric juice is an acid substance. Releasing it should make meal to be neutralized and to act positively for digestion, not for damage. It is clear. But if not, it is able, especially in combination with other aggressive factors, later about these factors, to damage gastric mucosa. Also, what else? Dietary factors are important. Very hot meal, if it is taken regularly. excess coffee, alcohol, and spices. But separately, excess of coffee, for instance, it is not important. Only together with other factors, and also as well as about spices. In Asia countries, many people eat very spicy food, but the morbidity in gastric ulcer is not higher than in Europe. Next group, ulcerogenic factors, is remedies, especially non-steroid and steroid anti-inflammatory drugs are famous of ulcerogenic effect. We know that both this group of anti-inflammatory drugs act on cyclooxygenases, which normally are important for the prostaglandins and other eicosanoids synthesis. Why eicosanoids are so important in the stomach? Because they support stomach circulation. Please do not say that aspirin itself directly damages gastric mucosa. It doesn't. Never. It only acts on eicosanoid synthesis. And stoppage of this synthesis leads to inappropriate blood supply, problems with regeneration of epitheliocytes, and possible, and the line possible, not obligatory, ulcer formation. The third group, bad habits, alcohol consumption and smoking. Both these substances are able to support vasoconstriction and again decrease blood supply and regenerative abilities and the formation of hypoxic injury of gastric mucosa. Heredity. What is the role of heredity? In 40% of all cases of gastric ulcer, we can find out that in a family where ulcer patient is, some other relatives suffer in many generations, as a rule, suffered from gastric ulcer or at least from gastritis. But it is multifactorial kind of disease. Multifactorial, you know that it is a kind of disease when not only one gene is responsible for a disease. Some genes are responsible, but not directly for the appearance of ulcer, but for some factors, for some weaknesses, I would say, in the stomach, or for some specificities which allow to ulcerogenic factors to work more, to work harder for ulcer formation. And later we will see how is it going. But nowadays, infectious factors are considered to be very important in ulcerogenesis. The most famous it is Helicobacter pylori, but not only, some viruses like herpes virus and other bacteria or fungi. Some statistic, Helicobacter pylori is revealed in about 80% of duodenum ulcer and about 60% of gastric ulcer. Almost a half of cases are because of Helicobacter. And also, this bacteria causes about 327,000 new cases of stomach cancer every day, but special case of cancer. Not every stomach cancer, but post-ulcerous cancer, a case when previous ulcer is undergone of malignization, converts onto cancer. In this case, Helicobacter is also guilty. The most important in this bacteria is so-called CAG pathogenicity island. It is the fragment of DNA in this bacteria which is responsible for adhesion on the gastric mucosa. If it varies to higher adhesion, Helicobacter becomes more virulent, more pathogenic. And the target cells for Helicobacter are epitheliocytes, neuroendocrine cells, and leukocytes as well. As a result, Helicobacter initiates lymphocytes infiltration. It changes secretion and epitheliocytes lifespan, which becomes less. So what are mechanisms of colonization and by Helicobacter and following development of ulcer? After invasion, Helicobacter obviously is undergoing the acid stomach secretion, as any bacteria, as any foreign particle. But at the same time, Helicobacter produces urease, specific enzyme, which destroys urea from blood flow. Urea is always here, is always in stomach juice, arriving by diffusion, but if Helicobacter is here, urease destroys it with CO2 and ammonia. Ammonia reacts with hydrochloric acid and creates the local pH about 7, which is very comfortable, very favorable for Helicobacter. So Helicobacter has all opportunities to multiply more in this favorable pH. But not only urease is in Helicobacter, also mucinase is here. It destroys mucin. Step by step, Helicobacter multiplies, supporting pH 7, and at the same time it destroys mucin nearby this colony of Helicobacter. As a result, gradually viscosity of mucin becomes lower, and at the same time Helicobacter appearing on the mucous membrane start to inhibit of mucin synthesis. So more condition, more opportunities to Helicobacter to be at the surface of unprotected mucous membrane. Also, Helicobacter has spiral form and high motility. And finally, it invades stomach epithelium, damages it with one more enzyme, bacterial phospholipase. And being damaged, cellular membranes express adhesive molecules. Specific changes take place on the lipoproteins of epitheliocytes, which are converted onto so specific molecules, which are able to bind with Helicobacter pylori. So adhesion is here, and Helicobacter damage epitheliocytes further. And now let's go back to inheritance. People with blood group O, the first blood group, have more antigen determinants responsible for Helicobacter adhesion. Nobody knows why, actually, but it is proved that people with group O have more predisposition generally to GIT pathology, especially to hyperacidic gastritis and gastric ulcer. Perhaps because they have antigen determinants for this Helicobacter pylori. Actually, only 10% of these bacteria are adhered as a result of these processes which we discussed before. But it is enough. It is proved that it is enough for the following pathogenesis of Helicobacter ulcer. Here it is the scheme which I previously told you. It is the invasion of Helicobacter through the mucous membrane. Here are processes of neutralization of acid through the urease action. Then further multiplication and colonization of bacteria, and so-called infectious center is already here on the surface of mucous membrane. And now a lot of bacteria, they are able to destroy cells, you see, destruction of cells, and further destruction of mucosa, by the way, inhibition of cells which synthesize mucin, and now you see inflammation is here, and neutrophils arrive in response on the release of specific chemoattractants, but neutrophils release more inflammatory mediators which are able to destroy epitheliocytes, and finally destruction of these cells together with inhibition of their lifespan lead to the defect formation, ulcer formation. So this is pathogenesis, typical pathogenesis of Helicobacter ulcer. Helicobacter ulcerogenesis is a very complex process. We told about epitheliocytes affection, and damaging of these cells leads to the release of inflammatory mediators which affect other cells. For instance, interleukin 8 affects D cells. You know, D cells, one of the types of the cells of diffuse endocrine system, which normally release somatostatin, inhibiting parietal cells. This regulates hydrochloric acid synthesis, but here interleukin 8 inhibits these cells. So no inhibition of parietal cells by somatostatin, but at the same time immune cells like neutrophils are also affected, or lymphocytes as well, and they release interleukin 1, which acts positively on G cells, forcing it to synthesize more gastrin. You know, gastrin is the strong stimulator for parietal cells for proton pump to release H+, acid radicals. So more gastrin, more acidity, and more aggression of stomach juice. And in 1996, Becci and co-authors discovered that duodenal ulcer, but it is also true to the gastric ulcer, this ulcer is the result of two-step processes under the action of Helicobacter pylori. At the first phase, Helicobacter initiates gastrin concentration increase because of somatostatin and cholecystokinin effects of abolishment. In the second phase, prolonged hypergastrinemia leads to ECL cells hyperplasia, and these specific cells synthesize excessively histamine. And histamine also is a stimulator of parietal cells, so it also supports hyperchlorhydria, hyperacidity, together with other mechanisms which also are supported by Helicobacter, damaged by Helicobacter. So hyperacidity may be formatted under Helicobacter effect. Also, in addition, the number of parietal cells increases as well as their histamine receptor sensitivity. So parietal cells start to multiply more, excessively more. And at the same time, their histamine receptors, which are normally on the surface of these cells, increase sensitivity under the negative action of Helicobacter pylori. So acidity increases, and additionally, Helicobacter pylori both changes epithelium proliferation and initiates apoptosis. It damages directly epithelium, and at the same time, it may initiate Helicobacter itself, adhering on the surface, only adhesia, not damage, not even damage, but only adhesia is able to initiate apoptosis of epitheliocytes. So, very, very dangerous infection. But not only, unfortunately, not only Helicobacter, but also opportunistic fungi. Now it is discovered that some fungi are able to play a role in ulcerogenesis. They may join the ulcer because of some factors. I would say that the most important factor is low immunity, because who has fungi ulcer? People with low body mass index and hypoproteinemia, for instance. What does it mean actually? It means that people have low immunity. Obviously, low proteins, low immunity. It is direct dependence. And as a rule, people with hypoproteinemia have low body mass index. Also, fungi join the ulcer when it is the significant ulcer defect. Again, something wrong with immunity and reparative processes. Also, if low acidity in stomach, it is very strange, but sometimes ulcers may be in low acidity. And together with low acidity, atrophy of gastric mucosa. Again, a low regeneration, a low immune response. And more often it happens in antral ulcer localization. Nobody knows why, but statistically it is proved. Very early, humankind suffer from ulcer, and very early physicians guess how is it going, ulcerogenesis. The earliest theory of this process is mechanical theory by famous German scientist Aschoff. It explains the ulcer as mechanical damage of stomach mucosa by food. But only it can explain the ulcers in the small curvature, so-called gastric path. But what if ulcer is in another part of the stomach? This theory is unable to explain it. The next theory is inflammatory. It is what was proposed in 1930s when the investigations of inflammatory mediators were higher. Humankind started to know more about inflammatory mechanisms. So many diseases people attempt to explain by inflammatory mechanisms. This theory explains well ulcers after gastritis, but not only gastritis is guilty in ulcer formation, and not every ulcer appears after gastritis. We know well now this. Next theory, vascular, proposed by famous pathophysiologist Virchow. It explains ulcers in people with atherosclerosis in gastric arteries, but we know that many people suffering from ulcer are quite young people before 30, when atherosclerosis is not common. So vascular theory doesn't work in this case. Next theory is peptic by Clin. It explains very well ulcers in hyperacidity, but we know again nowadays that not every ulcer develops in hyperacidic stomach. And the last one, corticovisceral theory, was proposed by Bykov and Kursin, Russian scientists, in 1952 in famous Pavlov's laboratory. Both Bykov and Kursin, based on Pavlov's theory of neurosis. You know this theory well, when, according to academician Pavlov, in central nervous system there is a collision of inhibition of excitation, and a neurosis is formed. So the scientists tried to explain ulcer as the result of cortical neurosis through the formation of dominant focus, about which I told you today, and about which you were told previously at the second year. So if dominant focus is formed in some individuals, in some people, this focus is able to excite nervous vagus centers and to increase acidity, and together with other factors, or even without any other ulcerogenic factors, is able to produce damage of gastric mucosa. Nowadays, we consider that pathogenesis of ulcer is a very complex process, and here It is an attempt to find out how is it going. So in shells, it is the imbalance between aggressive factors and protective factors. Number one in aggressive factors, it is acidic factor. Then inadequate meal, sometimes bile acids, if regurgitation takes place, Helicobacter pylori, some drugs, whereas protective factors are mucosa, first from the first, then adequate blood supply, regeneration, appropriate neutralization, so taking meal, intraduodenal inhibition or push-L evacuation, and prostaglandins. If balance between these two groups, there is intact mucosa, healthy stomach. If imbalance takes place, for instance, more aggressive factors or less protection or both disturbances, will be changing of balance to ulcer area. And regulation and inheritance are both able to support protection or to support aggression, depending on the particular co-interaction of these factors. Some more about bile acids and isolecithin role in ulcerogenesis. If regurgitation of bile takes place, it is acid substance which adds acidity to stomach juice and additionally damage it, leading to necrosis, acidosis development, liberation of histamine, vasodilation and edema. And additional aggressive factor takes place, but it is not obligatory that bile acids and lysolecithin appear in the stomach. It is an additional mechanism which may work sometimes in particular patients. What happens in endocrine mechanisms of ulcerogenesis? As you remember, hypothalamus rules under the almost all endocrine system, and in the case of excitation, it leads to release of excessive ACTG. ACTG stimulates glycocorticoids, which decrease mucus secretion, mineralocorticoids, which increase, and additionally, through the hypothalamus, adrenaline release is stimulated, which leads to vasospasm in stomach. Here it is some words of regulation of parietal cells together with some drugs which are able to inhibit it. So regulation takes place through the nervus vagus and the specific muscarine receptors of type 1. Also, G cells releasing gastrin stimulate parietal cells at the same time. And mast cells releasing of histamine through specific receptors are able to stimulate H plus release. So how can we regulate these processes by drugs? Muscarina receptors inhibitors, cholinoblockators, maybe gastrosipin, for instance. Atropine blockades receptors or to cholesterol, to acetylcholine, sorry, on the parietal cells directly. Gastrin receptors may be blockaded by proglamid. Histamine receptors type 2 we blockade by ranitidine or famotidine, specific blockators. And finally, omeprazole blockades proton pump directly, preventing release of H plus to the stomach juice. And to sum up, what do we consider now the real pathogenesis of total pathogenesis of stomach ulcer? Now, despite the many factors, many recommendations for the treatment of stomach ulcer, now we still consider that the first step is psycho-emotional stress. Not Helicobacter pylori is the first, but psycho-emotional stress. Psycho-emotional stress existing for a very long time or repeating for a very long time or being so strong forbids dominant focus, which in some cases in predisposed people leads to the second step, endocrine, when corticotropin is increased. What does corticotropin do? I told you on previous slides. It disturbs a release of corticosteroids, mineralocorticoids, and glycocorticoids, and additionally, directly psychoemotional stress obviously leads to increase of catecholamines synthesis. Both corticotropin and catecholamines release may lead to local mechanisms initiation. And additionally, if some external factors exist, for instance, non-steroid or steroid drugs intake, bad habits, inappropriate diet, or something else, these mechanisms, together with total neuroendocrine disturbances, lead to injury of gastric mucosa and finally ulcer formation. And local mechanisms also may Helicobacter pylori included, but statistics prove that the majority of people, about 60–80%, are infected by Helicobacter pylori. But fortunately, not everybody, not 60% at least, suffer from ulcer. So we shall understand that Helicobacter pylori is one among many other factors of ulcerogenesis, possible factors. But the main thing is still psycho-emotional stress. How would we treat gastric ulcer? It depends on existence or absence of complication and also on the stage of the disease and presence of Helicobacter. Helicobacter is not the main factor, but very important. We shall take it into account. So, principles of therapy is decrease of acidity, regulation of motility, and protection of epithelium. What drugs are used, you will discuss on clinical pharmacology. So, and additionally, we add eradicative drugs for Helicobacter and control this eradication. whereas Helicobacter disappear or not. If it disappears, it is remission. If not, further eradication is prescribed, so-called second line. If complications exist, complications are bleeding, penetration, perforation, it is treated surgically. But additional to surgical therapy, anyway, we use these principles of hypoacidity, motility regulation, and epithelium protection, together with eradication of Helicobacter pylori, if Helicobacter presence. Briefly about the differences between first and second line. First line uses antacids, inhibitors of proton pump or something else, and antibiotics. Second line, additional we change antibiotic and use additional bismuth-containing drugs. Bismuth-containing drugs are very favorable in the treatment because bismuth is toxic for Helicobacter, but at the same time it is not absorbed from GIT, so it is not toxic for humans. And additionally, bismuth reacts with acid radicals and neutralizes gastric juice. So we finished with gastric ulcer and some words about different other diseases. Pancreatic pathology. Pathology of excretory functions of pancreatic gland. When what factors may produce this pathology? First of all, it is pancreatic duct occlusion. Then inflammation of pancreatic tissue, pancreatitis, or direct external damage of pancreas. The most important among these factors is pancreatitis, inflammatory disease of chronic or acute course, and different etiology. What usually causes pancreatitis? First of all, it is alcohol consumption, because alcohol is very tropic for pancreatic tissue. Pancreatic tissue is rich in lipids, but alcohol dissolves in lipids very well, so it may damage it very well also. Trauma sometimes, one more cause, direct trauma, for instance, in traffic accident. Then cholecystitis, because of tight connection between pancreatic duct and bile duct. Any problems in bile system may lead to the spreading of inflammation, spreading of the process on pancreatic tissue. Some direct tropic infections, for instance, mumps, flu infection, these viruses are very tropic to pancreatic tissue. Some drugs also, like diuretics or some antibiotics. And duodenal ulcer leads to so-called reactive pancreatitis, spreading of inflammation which surrounds ulcerous defect on pancreas also is possible. What is pathogenesis of acute pancreatitis? Two main factors are initial factors. So under the any etiology, two things happen. First is secretion stimulation, over-secretion, and at the same time, it's very important, occlusion of ducts. In inflammation. Edema is typical, so ducts are edematous and occluded. What happened as a result? excess of secretion of active secrete containing active enzymes stay in the pancreas, instead releasing to the duodenum. And these active enzymes damage all pancreatic cells. In response on cell damage, there is the release of cytokinase, active enzyme, which converts trypsinogen, precursor, to trypsin, active proteolytic enzyme. And what happened? Active trypsin finally appear in blood flow. Not only damage pancreatic tissue, it damages, but not only pancreatic tissue, but also it appears in blood flow. And what does it do here? It activates lipases, which break down cellular lipids and lead to fat dystrophy. Mostly it happens in pancreatic tissue, but sometimes in very high enzymemia, in very severe course of acute pancreatitis, fat dystrophy may also be in liver, for instance, in other organs. Also in bloodstream, in blood flow, trypsin acts on kininogens and leads to the synthesis of active kinins, bradykinin, serotonin, histamine as well. These substances are vasodilators, you remember, and vasodilation is systemic because it happens everywhere in blood flow. At the same time, under the trypsin, phospholipase A is activated. You know that phospholipase A is the key factor, key enzyme for the following eicosanoid synthesis and liberation: lecithin and lysokephalin release, but not only, prostaglandins are also released, which also lead to systemic vasodilation. And so-called pancreatic shock is based on this vasodilators release, not on the direct damage, not on the following necrosis of pancreatic tissue, but it is based on the enzymemia, number one, and number two, synthesis of vasodilators, systemic vasodilation. Stages of acute pancreatitis. First is the enzymatic toxemia, which was described on previous slide. Then temporary remission. Organism tries to compensate, obviously. Temporary compensation is successful, but only temporary. And then complications develops, like pancreatic shock. Vasodilation becomes strong and total, blood pressure drops, organs are in ischemia and hypoxia, so multi-organic failure takes place, so it's maybe very, very severe condition. Next syndrome is diarrhea. What do we call diarrhea? It is when more than 200 grams of feces per day. If extreme, it can lead to dangerous losses of water and potassium and acid-base disturbances. What mechanisms of diarrhea do we know? First is bacterial or secretory diarrhea. In this case, bacteria cause increase of chlorine secretion and reduction of sodium reabsorption. It is very, very strong process in cholera, for instance. Next mechanism is inflammatory diarrhea. It is caused by mucosal destruction, with outflow of fluid and blood. For instance, it happens in ulcerative colitis. Of course, in cholera, for instance, inflammation also exists, but predominantly cholera toxin acts initiation of increased cholerain secretion. But here in inflammatory diarrhea, in ulcerative colitis, only mucus destruction prevails. Osmotic diarrhea. Some osmotic active substances in the gut lumen may bind a lot of water and increase the volume of feces. For instance, some salts, for instance, excess of fibers may work so. Diarrhea following ileal resection. You know that bile acids are normally reabsorbed in terminal ileum, in terminal parts of small intestine. Ileal resection decreasing the surface, decreasing the length of ilia of small intestine, force bile acids enter the colon, large intestine. But for colonic mucosa, for large intestine mucosa, bile acids are toxic substances, abnormal substances, and they stimulate secretion of water in large volumes, so diarrhea takes place. Vomiting. It is initiated by the feeling of nausea, as we told at the beginning of the lecture, and an array of sympathetic and parasympathetic responses. Sympathetic response includes sweating, pallor, increased respiration and heart rate, dilation of pupils, whereas parasympathetic responses include profuse salivation, pronounced motility of esophagus, stomach and duodenum, relaxation of esophageal sphincter, and finally duodenal content is forced onto stomach by antiperistalsis. So that is all what I told you. Thank you. Goodbye. Lecture is over.